All right, let's talk about retinoblastoma. If you're a pathology trainee, getting an enucleated eye is one of those moments where you know you have to be on your A game. This is way more than just a diagnosis. We're talking about a child's future here. So in this explainer, we're going to walk through the CAP protocol, step by step, to make sure you can handle this critical specimen with total confidence. So here's our game plan. First, we'll cover the why. Like, why is this protocol so rigid? Then we're going to follow the specimen on its journey, right from your grossing bench to under the microscope and all the way to the final synoptic report. And most importantly, we'll connect all those details back to what they actually mean for the patient. So why all the strict rules? Well, it really boils down to two things: precision and patient safety. Retinoblastoma is rare, which means every single case has to be handled in a standardized way so we don't miss a single crucial detail. These details directly guide treatment. And let's be real, on a practical level, following this protocol isn't a suggestion, it's a hard requirement for CAP accreditation. Now, the backbone of this whole process is synoptic reporting. Seriously, this is mandatory. The format is always data element followed by a response. This simple structure is brilliant because it just eliminates any confusion. It forces us to answer every critical question, making sure the oncology team gets a report that's crystal clear and, most importantly, actionable. Okay, let's get our hands dirty, metaphorically, of course. The specimen, an enucleated globe, lands in your lab. From this point forward, every single thing you do is setting the stage for the final diagnosis. Meticulous grossing isn't just a step, it's the absolute foundation for getting this right. First thing you need to know, patience is key. This globe has to fix for at least 48 hours. And here's a huge tip. Do not, I repeat, do not inject fixative into the globe or cut windows in it. I know it feels like you're helping things along, but trust me, you're just creating artifacts that will become a total nightmare when you're trying to evaluate it microscopically. Listen up, because this is probably the single most important step in the entire grossing procedure. Before you even think about cutting into that globe, you have to ink the surgical margin of the optic nerve and take that section. Why? Because retinoblastoma is an incredibly soft, crumbly tumor. If you cut the globe first, you risk contaminating the single most important prognostic factor on the whole specimen. Okay, once that margin is safe and sound in its cassette, your next cut is the PO section. P is for pupil, O is for optic nerve. This one slice should go right through the center of the pupil, the main tumor, and the optic nerve head. This is your money shot. It gives you the best possible view for assessing if the tumor has invaded the optic nerve head, especially that crucial area called the lamina cribrosa. The last step at the grossing bench is dealing with the two remaining halves of the globe. We call them culottes. You're just going to breadloaf these from front to back and submit all of it. This ensures you've sampled everything. So, at the end of the day, you should have 4 cassettes: the optic nerve margin, your PO section, and the 2 culottes. That way, nothing gets missed. All right, we're moving from the gross bench to the microscope. This is where we take all that careful prep work and start translating the patterns we see on the slide into information that has a direct impact on the patient's prognosis. First, just some basic orientation. We talk about 2 main growth patterns. If it's endophytic, think of the tumor growing inward, into the vitreous humor. If it's exophytic, it's growing outward, into the space under the retina. Noting this is just part of describing how the tumor is behaving. Now we're getting into the really high-risk stuff. First up, choroidal invasion. But what does true invasion actually look like? The CAP protocol is super specific here. You need to see a solid nest of tumor cells that's clearly filling or replacing the choroid, usually with pushing borders. And making this distinction is critical because of a really common pitfall. And here it is. This is a pro tip you have to burn into your brain. Retinoblastoma is soft. It's so easy to get artifactual floaters, basically loose cells that get pushed into the choroid or other spaces when you're sectioning. These are not true invasion. Real invasion looks organized. Floaters are just random noise. Getting this call wrong can totally change the patient's treatment plan. So, once you're sure you're looking at true choroidal invasion, you have to measure it. And the magic number is 3 millimeters. If the nest is less than 3 millimeters, that's called focal invasion. If it's 3 millimeters or bigger, that's massive invasion. And that distinction is a huge deal because massive invasion is a high-risk feature that bumps up the tumor stage and will probably mean the child needs adjuvant chemotherapy.
Okay, time to put all the pieces together. You've done the gross exam, you've done the microscopic exam. The final step is to synthesize all those findings and translate them into the standardized language of the PTNM staging system for your synoptic report.
This table is a really great way to think about the T categories. Just picture it as a ladder of invasion. On the bottom rung, PT1, the tumor is totally contained within the eye. Move up to PT2, and you've got some local invasion into structures like the iris. PT3 is where you find those major high-risk features we just talked about, like massive choroidal invasion. And at the very top, PT4 means the tumor has broken out of the eye completely.
And this is what that looks like in the final report. It's clean, it's direct, there's no ambiguity. The data element is extent of optic nerve invasion. Your response, based on what you saw, is posterior to lamina cribrosa but not to end of nerve. There's no room for guessing. The oncologist reads that and they know exactly what's going on and what they need to do next.
So we've gone through all the steps of the protocol, but let's end with what's most important, the why. Why we are so incredibly meticulous. It all comes back to the huge impact our report has on a very young patient's life. When you get right down to it, your entire exam is a hunt for these critical, high-risk features. These are the things that we know are linked to a higher risk of metastasis. Whether you find these or confirm they're absent is what will determine if that child needs additional, potentially life-saving chemotherapy. I want you to just let this sentence sink in. Of everything you look at, the status of the optic nerve is number one. It is the single most important predictor of survival. That's why we were so careful way back at the grossing bench to secure that margin before we did anything else. It all connects. So that's the question you should be asking yourself every time you get one of these cases. Your work isn't just technical. It's not just another specimen. It's a profound responsibility. The details you find and the accuracy with which you report them will literally shape the course of treatment and help define a child's future.